Thanks for coming. Hello, everyone. I'm Diane Masciangelo, and I'm one of the nurse practitioners that works in the MS clinic. I work with Dr. Jacqueline Nicholas and Dr. Aaron Boster. In addition to myself, we have a couple other nurse practitioners. We have Colleen O'Connell and Jeanette Ripley and Laura Poplar. Laura works with Dr. Eubank, another one of our neurologists that manages MS here at OhioHealth. So welcome. Thank you all for coming. As you know, we started doing these talks and then we started combining them with Tracy's wonderful support group, and then we learned that that was so much better that we could just piggyback on to support group. But today is Tracy's birthday, so happy birthday to Tracy. Yay! So we're having a party for her tomorrow. Don't tell her if you see her before then. But that's why there isn't a support group today. So when you see her next time, be sure to wish her a happy birthday. So in my role as a neuroscience nurse, Christy and I have been working together for many, many years. I started here in 1987 as a nurse in the neuro critical care unit right out of college. And it was only 4 beds at that time, and our unit was a little smaller than this room that we're in today. And neuroscience at OhioHealth has changed a ton since then. And we are very fortunate and blessed to have this Dempsey Center for education and an opportunity to get together, because I think we learn from each other every day. And even though this tape has been videotaped before, there'll be different questions this time, which we'll learn different things. So this is very informal, so please stop me at any time if I say something that doesn't make sense or if you have specific questions. But tonight we're going to talk about MS and fatigue. And fatigue is one of the most common symptoms that I hear about. So I see patients every day in the clinic, and our role as providers, both nurse practitioners and physicians, are not only to stop the disease from progressing, so using disease-modifying therapies to stop that, as well as managing the symptoms that have been caused by previous attacks or demyelination, and making your quality of life better. So that's my job every day. That's what I get to do, which I love. So when I first started working on this talk at the request of Dr. Boster, I started looking up what is the definition of MS fatigue and how is that different than just regular old fatigue. You're just tired. Well, it's a lot different. But this is the definition that I found. So I'm going to read that to you. A subjective lack of physical and/or mental energy that is perceived by the individual or caregiver to interfere with the usual and desired activities of a person's day. What do you think of that definition? Do you think that that definition kind of sums up what fatigue is for you? How many people have fatigue with their MS? So 100% of the patients with MS have fatigue in this room, okay? So that's even higher than what the statistics tell you. So does that meet would you say that that's active, or that's an accurate description? Because for
caregiver, yes, but it's pretty vague.
It's pretty vague, and it really doesn't really speak to the severity of fatigue, in my opinion. Because what I hear in the clinic and in the office setting is it's much more than that. It's the kind of fatigue that you are unable to do things that you normally would want to do. So you are completely exhausted. You wake up and your battery feels like it's on E after a full night's sleep. You can't, you get to work, but then when you get to work, you're absolutely exhausted just from getting yourself together and getting yourself to where you need to be. So this is the most common symptom that we hear. And there's lots of things that we can do to help with fatigue, which is very encouraging. But this is one of the leading reasons people leave the workforce. So it is a symptom that you can't see. It's one of those invisible symptoms of MS, right? People can't tell that you're tired. They can't often see how fatigued you are. It is reported severe in about 74% of patients. And the quality of work life and the leaving the workforce are the 2 biggest reasons why we want to manage your fatigue, okay, as providers. So why does it occur? Well, we're really not sure. We know that in MS, it is both a demyelinating and an inflammatory process in the brain. We don't see a correlation to someone who has many, many lesions having more severe fatigue. You could have a few lesions in your brain and have lesions in your spinal cord, but you could have very devastating severe fatigue. Versus you could have a lot of lesions in your brain and not have very severe. So there's not a correlation with that, but we do know that the central nervous system is not functioning normally because your immune system is different than others. So your body, your immune system thinks myelin is foreign and it's going out and attacking it. So that is why we aren't sure why fatigue is so severe in some patients. So we're going to talk about two types, central and peripheral, tonight. And this little skit, this little cartoon, really sounds more like what I hear. So MS fatigue is like someone who's just hiked 20 miles up a steep hill after 2 days of no sleep while carrying a backpack that's loaded with rocks on the hottest day of the year. That is MS fatigue. Okay? It's the moment when your legs can no longer hold you up, every muscle, every bone, even your eyelids hurt, and as soon as you sit down, you are out and out to the world. A tornado could go through and you would still sleep. So I hear that every day from my patients. I went to work, I came home, I tried to cook dinner, I sat down on the couch, I was out. That was the end of my night. Okay? So that is more typical what we hear on a daily basis. So what's the different types of fatigue? So central fatigue is also, you'll hear it called pathologic fatigue or cognitive fatigue or cog fog. So this is just kind of, you are out of order. Things aren't working. You are physically, mentally exhausted. You wake up in the morning and you feel like your battery's on E. Okay? Even after a good night's sleep or rest, this doesn't help. Yep, no matter how much you sleep, it doesn't work. You wake up and you're fatigued. So you can see as having that cog fog, not being able to focus, having word finding difficulties, having trouble comprehending. You might be reading something at home or at work, and you're like, I just read this, and now I'm reading it again. And it's because you have that cognitive or central fatigue. And then peripheral fatigue is more of motor fatigue. So you can have one or both. One could be worse than the other. But the motor fatigue is when you do pretty well, but you start walking, and after you get to your car, you feel like you have to sit down. I had a patient tell me that they did their grocery shopping in 3 trips because they could only get down the produce in the first 2 aisles and then go home. And then the next day, do the center part of the store, and then the last day. So you can see how that motor fatigue can be very devastating to someone's quality of life. So it is depleting, it's fatiguing, it's progressive weakness with prolonged use. And this does help if you can rest. That is usually therapeutic for people with peripheral fatigue. Any questions about those two different types so far? So when we talk about peripheral, it's more the motor fatigue, wearing out, not having the stamina, and the central or cognitive fatigue is more pathologic, memory thinking, everything, exhausted. So when a patient tells me that they're fatigued, there's a list of things that I like to talk about. And probably at the top of the list, even though this isn't at the top of this list, but the first thing I ask is, are you sleeping? Because sleep is so important. And you could be sleeping 18 hours a day. That's not good either. But are you able to fall asleep? Are you able to stay asleep? And then what's keeping you from doing those things? So I think it's so important that we talk about sleep, because that's when all of your short-term memories get turned to long. That's when you're recharging your battery. You're going to feel better. Anytime you're fatigued, all of your other MS symptoms are worse. So we want to correct that. Do you have restless legs when you lie down at night? Do your legs start jumping? If that's the case, you want to talk to your provider about that, because we want to check your iron studies to make sure you're not iron deficient. That could be a sign of restless legs, or there's some medicine that we can try. Are you having trouble falling asleep? Is it because you're anxious or depressed or worried? If that's the case, then we gotta address that, okay? And then, are you having trouble staying asleep? So nocturia is you're up all night going to the bathroom. So if your bladder is affected by your MS, let's talk about that, because we don't want you getting up 4 or 5 times a night to go to the bathroom. That's interrupting your sleep pattern, and that's going to make your fatigue worse. There are also other sleep, besides obstructive sleep apnea, there are other sleep disturbances that could be identified through a sleep study. How many have had sleep studies done here in the room? Quite a few. So they're not pleasant, but they give us a lot of information about how long you're in REM sleep, how long it takes you to fall asleep, how many times you wake up during the night. So if you are having issues with sleep, we're going to kind of start there. So it's a very important thing that really contributes to fatigue. So that's at the top of my list. Any questions about that?
I don't have a question, but can I interject kind of an opposite thing?
Sure.
With Sweet Gretchen here. At the beginning of the night, when we first go to bed, she thrashes about and she dozes off for 5 minutes, and then she's awake asking me what time it is. Why are you still up? Well, I'm still up because I just went to bed.
Yeah.
And this goes on for like 2, 3, 4 hours, and then she'll go to sleep and sleep well.
Mm-hmm.
But
So that's
you're
the falling.
talking about
It's
kind
the.
of fatigue where you sit down and suddenly you're out.
Mm-hmm.
She seems fatigued, but it'll take her 2, 3 hours to actually calm down
to
enough
sleep.
to sleep.
Okay.
And they've looked at her meds too, trying to adjust that, but it doesn't really help.
And are you napping during the day, Gretchen? Doze off?
She'll sometimes lay down and take a nap.
Mm-hmm.
She may sleep 15 minutes, or she may be upright, up and down, up and down.
Yeah. So we like to look at any medications that are stimulating and could cause that to happen. We'd also want to look at shortening any naps. So a nap more than 20-30 minutes in a day can really affect your sleep and your ability to fall asleep. So.
She's always kind of been hyperactive with this MS,
Mm-hmm.
but she's also in a wheelchair now, so we're trying to vent the energy. I don't know if that, is that
So
a
spasticity,
buildup of
if you're
energy by the time she can't sleep?
right, and if you're more active during the day, you could have more restless legs or more spasticity at night too. So if that kind of restless movement is happening, we should talk about that with your provider. You had a question?
Yeah, I think for me, I don't have a problem sleeping. It's just when I get up, it's like I haven't slept.
Mm-hmm.
Because I could be at work and like I could be at work for a half hour and feel like I haven't gotten any rest at all. And I'm like tired.
Mm-hmm.
So, and I fight naps because I don't want to be up.
Interfere with sleep, yeah. Do you have trouble falling asleep?
No.
No. Okay, you just aren't rested.
I'm
No.
having trouble falling asleep.
All right.
At all.
And you're not having time, you're not waking up during the night, you just aren't getting restful sleep.
I usually wake up at the same time every
Yeah.
morning, and that's at like 5 o'clock to
Mm-hmm.
use the bathroom. But
Mm-hmm.
once I get up, it's like I haven't had any sleep. So it's like, am I sleeping?
Mm-hmm. And have you had a sleep study yet?
No, I
Yeah. So that would be probably my next step recommendation. And if you are sleeping well, is that just really the cognitive pathologic fatigue that despite rest, you're still tired? But we want to rule out that there's nothing else contributing to that first.
don't have a problem falling asleep.
That's good. That's good. All right. Other questions about sleep? Okay, so next is depression or mood disorder. So we know about patients with MS are much higher risk for depression, and anxiety, both. We know that areas of the brain that are affected by the MS control mood, as well as just dealing with a chronic illness. You know, MS is something you're going to have the rest of your life. You have these symptoms that you have to manage. So because of that, mood can be an issue. So if you're feeling down, that can interfere with sleep. Depression can. So we want to, or anxiety, if you're anxious and thinking about things and can't turn it off when you lay down at night, we want to know about that because we want to manage it so that it doesn't contribute to your fatigue or make that worse. Spasticity is another thing. So patients that suffer from spasticity, it's very difficult because it takes you more energy. You're expending more energy to work with an extremity that is spastic. So if you're walking and or just having a lot of spasms, even in a wheelchair, that can affect your sleep at night as well. So we want to make sure that your spasticity is managed. If you have extremity weakness, arm or leg, or both legs, you're going to expend, again, more energy. So patients with MS, you know, we're making sure that you have the right physical therapy, exercise program, and any assist devices to make that easier for you so you burn less energy and you're less fatigued in walking. Neuropathic pain is another very common one. So neuropathic pain can be a variety of things. It's not always pain. It can be itching, it can be burning, it could be a hot or cold sensation, it could be numbness, it could be tingling, it could be feel like an extremity is asleep or trying to wake up. So having neuropathic pain affects fatigue because a lot of the medications that we do treat neuropathic pain with cause what? Sleepiness, right? Or fatigue. So having that, we don't want it to interfere with your sleep, but we also want you to be on the right dose of medicine to prevent that from worsening. Does that make sense? So if you have any neuropathic pain that could be affecting sleep and or quality of life, getting you to do the things you want to do, we want to treat that. So let us know about it. But most of the meds that we do treat with neuropathic pain for can be, one of the side effects is sleepiness. So just want to make sure we're on the right doses of that. Iatrogenic medications, again, those are things that cause sleepiness. There are some blood pressure medications that people are on that make them sleepier than others. There's antidepressants that are less stimulating than others. There's baclofen and gabapentin. Those are all medicines that can contribute to fatigue. So we want to make sure that med list is very clean, and we talk about our meds every time you come in, what's working for you, what's not working for you. Okay. Alcohol and drug use, we know that those both can contribute to fatigue. Too much of the alcohol can interfere with sleep. So if you have more than a drink or two, you notice that your sleep will change, and that also can contribute. And then deconditioning, lack of exercise. So not getting enough exercise will definitely make your fatigue worse. We know that we have a wonderful program, MS Wellness and MS Fitness here at OhioHealth. If you haven't been introduced to that, talk to your provider or your physical therapist about that, because the more active we can keep you, that will, if you're inactive and deconditioned, that also contributes to fatigue. So we want to have you in a program to help with that. And then other health problems, so things like hypothyroidism, B12 deficiency, other health problems, restless leg syndrome, all of those things can contribute to fatigue. If you're diabetic and having your sugars out of control. So you have to look at kind of the whole picture, just not the MS part of each person. Okay. How many people have heard of the spoon theory? Tell us what you know about the spoon theory, Tim.
Excuse me?
What do you like about the spoon theory or know about the spoon theory?
It was an interesting explanation of I heard from Dr. B, so the way he described it, it was an easy way to encompass progressing through the day?
So the spoon theory is a way to kind of communicate with others how much energy you have left for the day, or how much energy you have, period. So this was developed by a patient with lupus that wanted her family to understand what chronic fatigue was. So lots of autoimmune diseases have fatigue associated with them, not just MS. And so the spoon theory is you have so many spoons when you wake up in the morning. So you have 12 spoons, okay? Or whatever number you want to say. You could say 20, because our physical therapist, Lauren, she says, you got $20. How do you want to spend it today, okay? So if, for instance, if I had some weakness on the right side of my body and spasticity, you know, it might take me 5 spoons to get myself showered and dressed. And then by the time I get to work, I'm 10 spoons in. That means I have 10 spoons left for the rest of the day, and I haven't even started my day yet, okay? So it's about how you want to spend that energy. If you know you have something really important you want to do that night, whether it's go see a grandchild or child, go play a sporting event, or you know you want to go out to dinner with friends, or you want to go to a movie, you know, you have to plan for that. So that wouldn't be the day that you work all day and then run and do a couple of errands and then expect at 5 or 6, 7 o'clock at night you're ready to go do something else, because you're going to be out of spoons, out of energy, okay? So it's a way for other people to understand how tired you are, how fatigued you are, because it's okay to say, you know, you could say, I'm exhausted, I can't do this. Or you could say, I've got 3 spoons left. How do you want me to spend that tonight? Do you want me to do homework? Do you want me to do dinner? You know, what do you want me to do? So I think it's a good way to communicate with people that love you how you're feeling, because fatigue is an invisible symptom of MS. We can't see it. We don't have a meter on the, you know, on your forehead that says you're on E. So I think the spoon theory is a really, really interesting way to do that. So I think it's helpful. And that way, you know, the people that don't really understand MS and how fatiguing it makes you, it will help them appreciate it more and appreciate you more. And, you know, you do have to say no thank you to a lot of stuff. And that's okay. You know, people that love you are going to understand that. And people that don't, well, that's too bad for them. You just have to keep doing what you need to do. So I think it's a good way, and I like to, you know, help my patients to think about that, because I think sometimes we think we can do all these things in a day. And if you do all those things, if you have 20 spoons to spend and you spent 30 today, what's tomorrow going to look like? Now you've only got 10 tomorrow, and that's the day you're going to lay in bed because you're completely exhausted. So we don't want that to happen. So I think it's a good way to communicate with people and to think about how much energy you have to spend. Questions about the spoon theory? You can Google it. It's quite interesting on the to learn more about it, but I think it's helpful. Supplements. So besides our disease-modifying therapies and the medications that we're on to help with symptomatic management, I think the most important thing you could do is take vitamin D, okay? We want our vitamin D level to be between 50 and 100. Yes?
Does it specifically need to be vitamin D3? Because my insurance company has all of a sudden decided that I have to pay for vitamin D3, but if my doctor will change it to vitamin D2, they'll cover it.
Yeah. So it's not absorbed as well as D3. So, but you could take D2, but you may need to take more of it. So all we need to do then is check that level at your next visit and keep an eye on it to make sure with D2 it's not, but yeah. And insurance companies make those kind of
Arbitrary
decisions, yeah. So, yes?
What did you say the level should be?
Between 50 and 100 is where we'd like it to be. So normal is 30 for an average person, but for a patient with MS, we know levels between 50 and 100, we saw less relapses and improvement in fatigue. So that's kind of where we want to keep it. The other 2 supplements are over-the-counter supplements, levocarnitine and CoQ10. And those both are thought to improve fatigue because it helps the cell at the cellular level. And both of those medicines, although they're over the counter, there are some side effects that you have to be sure that you don't have issues with kidney or liver, that you talk to your talk to your provider before you get on those medicines. But those are over-the-counter medications. The levocarnitine in particular, I've had some patients have some luck with, 1,000 twice a day. And you know, we just want to make sure there aren't other risk factors that we should avoid that medicine. So just talk with us about it. You can have too much D3, so there is such a thing as too much of a good thing. I had a patient that had a D3 level like 150 and was nauseous, and that was why, because she had too much vitamin D.
Was she really taking a lot of supplements with it?
Yeah.
Or naturally she was.
She thought, well, if 5 was good, I'd take 10. If 10's good, then I'd take more than that. So she just was like, oh, I thought it was good to take more. So there is a limit to that. That's why usually at least once a year or every 6 months to check your vitamin D. So as far as, yes?
Have you noticed that a lot of people with MS have, one of the problems a lot of them start out with is having low vitamin D?
Yes, yeah. So it is one of those things that we see as a predictor. So low vitamin D, exposure to secondhand smoke, obesity as a child, and unfortunately in Ohio, you know, we have more gray days than sunny. So most everyone is vitamin D deficient, whether or not they have MS or not. So, but it's something that we can easily fix. That's a great question.
And can you tell me what is the maximum doses a person would put them on if their level is low?
If your level is low, it depends on how low. So if we have a level in the teens, then we tend to put patients on 50,000 international units once a week. And we do that for a 4-month period, and then we have you go to 5,000 daily, and then we check the level at that next visit. But typically 4,000 to 5,000 daily is enough for some people. Now if you're taking D2, you might need a little bit more, but it's individualized. But you know, 50 to 100 is where we want that to be. So the most important things for fatigue and controlling it is you're number 1 on a good disease modifying therapy. Number 2, that you don't smoke. Number 3, that you take your vitamin D, and that you exercise. So those are the 4 things that you can do to keep your MS quiet. Take a good disease modifying therapy, don't smoke, take vitamin D, and exercise. So then you're 4 for 4. So those are the 4 most important things that you can do for your MS. So if you're doing those 4 things, and we've looked at your med list, and we've looked at your sleep, and we've looked at your mood, and there isn't anything else we can fix, and you're doing everything, then we need to talk about, is it time to go on a medication for fatigue? Because it's about quality, right? Quality of life. So if you're still fatigued, and we haven't discovered any other reason for this, then, and you're doing all those things, then we want to start on a medicine that will actually kind of trick your brain into being more awake, being able to focus more. And those medications, unfortunately, every medicine comes at a cost. You know, with every, Dr. Boster likes to say we have a pill for every ill, but just because you're having a symptom doesn't mean you need a medicine for it. It depends on how that symptom is affecting your life, okay? So if this is affecting your life, then we should try to go on something to help improve that. So these are a couple of the medicines that we use, amantadine, Provigil or Nuvigil, and then the Ritalin, Adderall, Vyvanses of the world. And then Ampera is used for the motor fatigue and heat sensitivity. So the others are used more for the pathologic or cognitive fatigue. So talk with your provider at your next visit if you've done all those other things and you're still having issues with fatigue. What can we do to make that better? And if we've addressed all of them, then let's think about, is there a medication that you're willing to try? And there is no science behind this. Unfortunately, it is trial and error because no 2 people respond to medicine the same way. So we have to give it a try, see how you feel on it. You're like, I have this side effect or that side effect. I don't like this medicine. Okay, we'll stop it and let's try something else. So we'll continue to work with you as long as you want to work with us about improving that. Okay. The only contraindication, the Empira, if you have a history of seizures, you cannot take Empira, but the other ones are, have some, but that's probably the biggest one. So what can you do? I work smarter, not harder. So these are those things. Make sure that you're adherent with your disease-modifying therapy. So if that drug is something that you aren't tolerating or don't want to take, or you don't want to take your injection, then talk with your provider about that, because we want to make sure that this is something that you can tolerate, because this is talking about your future and preventing new relapse and demyelination and disability. Exercise is so important, no matter what amount of exercise it is. Exercise period has been studied over and over again that it makes a huge difference in people, not just mood, sleep, but also fatigue. So can't say enough good things about exercise. And there's lots of opportunities at OhioHealth and through our MS Fitness and MS Wellness classes that you can get involved with that. Sleep hygiene is so important, and you'll hear us talk about that in visits. So what does sleep hygiene mean? It means going to bed at the same time every night, waking up at the same time every day. It means not having a TV in your bedroom or any other electronics, because if you have those lights in your bedroom, it makes your amygdala, that part of your brain, think it's time to wake up. So if you're somebody who's having trouble sleeping and you keep looking at the clock, you know, you might want to get a sleep mask or put something so that something's blocking that clock. And if you are unable to sleep, you don't want to stay in the bed and toss and turn. You want to get up. If you're still awake after 20 minutes, get up, sit quietly, and read like an old-fashioned paper. You could read this handout again. Read something that's not that interesting. You'll fall right back asleep. That you go back to the bed. So sleep hygiene is super important. And little changes like that can make a huge difference. Make sure that we look at your medicine list every time and you understand what you're on and why you're on it. That's so important, okay? Because if you can't say why you're on this medicine, should you be on that medicine? So you have to figure that out. And if those medicines are things that worsen fatigue, is there something else we could use instead? Cognitive behavioral therapy is very interesting, and there are lots of psychologists, counselors, social workers out there that are doing CBT. Has anyone heard of it? So cognitive behavioral therapy is basically problem solving. So you think about an issue, maybe your fatigue, and you think about what things are contributing to it. And then, for instance, I'm not exercising. What can I do? What are the things that are keeping me from exercising? And then how can I problem solve and change that mindset so I'm willing to start exercising? Okay, so cognitive behavioral therapy works for lots of different things, not just fatigue, but anxiety or depression, or, you know, I don't want to go on a disease-modifying therapy. Why is that? What am I afraid of? And so they work through that with you. And it's basically just having you think about what's bothering you and then trying to find the underlying reasons, and then manage that. So it's been very helpful for many of my patients. And so if that's something you think you'd be interested in, talk with our social worker, Tracy, about it. Talk with other people in group about it. It can be very beneficial. And, you know, conserve your energy. Think about the spoons. Tell your family, I have 5 spoons left. I'm going to need you to go to the grocery store, okay? Or I'm going to need you to do this for me. It's sometimes hard to ask for help, but you have to conserve that energy. You want to keep that energy for the things that you prioritize as most important. And sometimes you have to let other things go, and that's okay. They're your spoons. You get to use them however you want to use them. And, you know, power naps. And by power naps, I mean 20, 30 minutes, not 2-3 hours, which would be my power nap. But because if you do more than 20 or 30 minutes, it will interfere with your sleep. And so then your sleep cycle will get off, and that'll worsen your fatigue. So set your alarm and make somebody get you up and go for a walk or go do something after 30 minutes. So what questions do you guys have? That's all the kind of information I want to throw at you. What are your thoughts or questions about fatigue? Or anything that you have a question about that I might be able to answer.
When I get fatigued, you can see it in my eyes. And my face, the expression on my face, it just literally goes down. And the more fatigued I get, the worse it gets.
It gets.
So all someone has to do is look at me and look at my eyes and say, oh, because yesterday at church there was one of the ladies was telling me that I looked fatigued, and I thought, I do? Because I was feeling
Feeling
good.
good. Yeah.
I didn't sleep good the Saturday night, so that played a factor in it too.
So even though you didn't feel it yet, she could see it on you.
Yeah.
And one night's sleep can make a big difference on how you feel, for sure. Okay. Yes.
I've got a question. Now, does working a full-time job make this more dangerous or more, I don't want to say life-threatening, but you know what I mean as far as making the MS worse? Can working a full-time job, like my daughter-in-law is working a full-time job, she has MS. I kind of worry about that. I think, oh, geez, she has MS, maybe she shouldn't be working a full-time job, except if she needs to. But.
Yeah. So it's not going to make the fatigue or the MS worse, but it can make the quality of her life worse. So if she's working full-time, and does she need accommodations at work? Are there certain things that, we as the provider and social work can talk with her about her job? Is it something that she could do from home for 2 days a week? Is it something that, certain projects she could have removed from her plate? Does she have enough support at home to do other things while she's working? Because lots of people that don't work outside of the home still are working all day long, taking care of people and doing other things. So it's not for in our experience, people that stay in the workforce longer do better, because you have that interaction with other people. You're cognitively using things and staying alert, and that social interaction and support group, even though you might have some coworkers that drive you crazy, you have some that are very pleasant to be around. And so you want that kind of socialization and support. So I think it's a good question. It doesn't make it worse, but we certainly want to do whatever we can to improve that and improve quality of life. And that's what symptomatic management of MS is about. We can't change those things, but how can we make those symptoms better for you? How can we want to make you your best you, and we want to know what you want to accomplish. If you say, I want to be able to continue to work full time and do this with my children outside of work, then how can we help you do that? Other questions?
Because I deal with tingle, my hands are tingly all the time. And some days are worse than others. Like the last couple of days, they were pretty bad. Today they're not that bad, but what can I do to relieve it?
So she's asking, with numbness and tingling in her hands, it's worse some days than others. What can you do to relieve that? So that is a definition of a neuropathic pain associated with MS, very, very common. So anytime you have an infection in your body, if you have not slept for a day, if you are anxious or got in a fight with somebody, you got your blood pressure worked up, anything that increases your core body temperature will cause those MS symptoms to be worsened. And it's called a pseudo-relapse. And it's pseudo meaning it's not a new symptom that's come on over 24 hours. and stayed more than 2 days. This is a chronic or an old symptom that kind of comes and goes and gets worse. So the first thing I like people to think about is what's making it worse. So can I attribute that to not sleeping for a couple of days? Can I attribute that to a cold that I've been fighting, or maybe a urinary tract infection that I don't realize I have? So those sorts of things. If it's interfering, if you're dropping things or you're having trouble working and using your hands, then we need to talk about a medicine to help with that.
My doctor, she put me on something, and at the time, I was having trouble sleeping, but it gave me bad nightmares, so I stopped taking it.
Okay. So can I ask what it was? Which medicine do you remember? Was it amitriptyline or was it? You don't remember? Okay.
But she said it has helped with seizures.
Uh-huh. Okay. So probably could have been gabapentin or Neurontin. Does that sound familiar?
I don't know.
Okay. So there's lots of different medicines that we can use for neuropathic pain, and almost all of them were developed for something else. So gabapentin or Neurontin was a seizure medicine. Trileptal, carbamazepine, those all were other for FDA approved for another reason. And then when those patients took it for that, they realized, oh, that numbness and tingling in my feet are gone. So now that's why we use that medicine. So the only thing I can say is we could just go back and tell them what side effect you had, and we'll figure out which medicine that was. Sometimes you can start on an even lower dose of gabapentin, 100 milligram capsules instead of 300. And some people just, are very sensitive to it. So I always start very low on a dose and go slow and talk with you about how you're responding to it. So there's lots of different things we can try. So just because you tried one, or you might have even tried it at a dose that you couldn't tolerate, we could revisit it and try again. Yeah.
Thank you.
You're welcome. Other questions? Comments? All right. Well, if there are no other questions or comments, I'll be here a while if you want to come up and talk to me after. Privately, I'm happy to talk with you, but I thank you for your time and thank you for coming tonight. And I hope that this helps a little bit, gives you some answers and or more questions to talk with your provider about how you're feeling and how you can, improve fatigue and any other symptom that you have associated with MS. Okay. Thank you. Thanks.